Thank you for the kind introduction. I'll come over this side, it'll be easier to hear. So in terms of the Prime Minister's, I'd forgotten this. The Prime Minister's Advisory Committee on Suicide Prevention, when I got on my Sri Lankan Air flight to Colombo on this trip, sitting next to me in the front of the plane was Scott Morrison, the former Prime Minister. So the Prime Minister who actually recruited me to that thing, he didn't recognize me, but he got royal treatment when he got off the plane. There was about 8 dignitaries to meet him, and they whisked him off to a side room. And anyway, so Scott came with me on this trip. Okay, so today I'm going to talk to you about there'll be a bit about suicide, but a lot about suicide attempts. And so what we would call different names in different countries and different traditions. But in Australia, we say deliberate self-harm. And that encompasses both deliberate self-poisoning, the more common form, and deliberate self-injury, usually cutting, burning, those sort of things. Anybody who's an ED physician will be very familiar with our patients at the front door of the hospital. I should also say, I understand that the conference in Colombo has probably drawn everybody from psychiatry there. So I'm very impressed that people from non-psychiatry would come to see this topic. Now, the framework that I'm going to try and tell you about is very popular in Australia at the moment. That's called a translational program. So the idea is that you shouldn't be doing any clinical service or any research unless it lies somewhere, of course it will, unless it is incorporated into the translational continuum. So something from an idea, from basic science up to implementation at scale. Well, let's see if I can get this to go forward. That's a pointer. Hang on 1 second. Page down, where are we? That doesn't. I'll put up a slide in a minute about the translational sort of continuum. So you first sort of identify a problem that you want to do something about. You have a whole sort of developmental phase. So long before you do an intervention and an efficacy trial, you have to develop your instruments for measurement, decide what the proper metrics are, decide how you're going to measure them, decide what the intervention is going to be. You have to pilot test that, see if the hospital where you're working and is going to apply it is able to do it. So there's a whole lot of planning of the idea, seeing what the scope of the problem is, developing the intervention, trying feasibility and training things that need to be done. So we can't make it advance. Okay, I think we have action. Okay, so summarizing, jumping to the end so that you can have a little nap if I get too boring in the middle. This is what I'd like to tell you. So hospital-treated self-harm, it's common, it's costly, even in this country. Repetition is a very important part of this. And if you have an emergency department in a general hospital or mental health services, something about reducing the frequency of repetition of self-harm, suicide attempts, overdoses will be part of your policy somewhere. There's still a lot of argument about the best metrics to use to measure repetition, which when you think about it, seems like a sort of simple idea, and I'll tell you about that today. And at least in our country, that the scale of the problem, the scale of the number of people coming to the emergency departments, which account for about 5 to 7% of all presentations to emergency departments in Australia, requiring aftercare is so large that even in a very well-resourced country like Australia, we will not be able to provide face-to-face follow-up for everybody. We won't be able to provide face-to-face formal psychological CBT therapies for everybody, no matter what. And so being able to deliver interventions at scale is definitely going to be one of the problems that needs to be solved. And so I'm going to now show the evidence to try and convince you that the brief contact interventions are acceptable, effective, inexpensive, cost-effective, and scalable, and can be used in the whole clinical population. Now, there are other interventions that have also shown to be useful in terms of reducing repetition of deliberate self-harm at the hospital, and they're the list down the bottom there, but I'm not going to deal with any of them today. There's a whole literature for each of those. This is research continuum, the translational research continuum that is the New South Wales health model. There's lots of other models of these things, but they all sort of have the same basic idea that you start here with an idea or a problem of what you want to address, what you want to improve. There's a business of feasibility and training and selection of metrics, efficacy studies, implementation in a normal hospital system, and then scalability, and then eventually in a mature system, ongoing monitoring of how your progress, what your outcomes are. And I'll try and give you a bit of a story of how we've done that with brief contact interventions. So this is a model of care that we developed in the Mater Hospital in Newcastle. And so for people who take an overdose and come to hospital, in the days before we did this, every hospital took overdose patients, no matter how big or small, regional or large, metropolitan hospitals. And if you came in with a cut wrist, you might get admitted under the orthopedic doctors in case you'd nicked a tendon. If you had a sort of sedative overdose so that you needed to be on the ventilator, you might get admitted under an ICU doctor or a respiratory physician, particularly if you'd aspirated a bit. If you came in with a seizure from your proconvulsive medications that you'd ingested, you might get admitted under neurology, and so on. So everybody got admitted everywhere. Nobody had a consistent plan of how to manage them. Nobody in those days was specifically trained in toxicology, which I know is a big interest here because of your toxicology unit at University of Peradeniya. So what we did was develop a regional service along the lines of acute trauma units or stroke units. So in those situations for, let's say, acute trauma units, rather than have every hospital in Sydney, Australia, run their own trauma service, we select out 3 geographically spread out hospitals to be the trauma centres. And at those places, we concentrate all the expertise. So the orthopedic doctors who are good at trauma, the neurosurgeons who are good at head trauma, the plastics guys who have to do a lot of the reconstruction of limbs and fingers and skin, the ambulance service that brings people there. So the golden hour of trauma, they were trained up to do roadside resuscitation, fluids, get people stable, get them to hospital as soon as possible, all the imaging facilities. So you concentrate all the resources at one hospital, you can be more efficient. And the political thing is you have to get the other hospitals to give up their trauma service to the big hospital that's going to own trauma. The good thing with people who take an overdose and come to the hospital, trying to politically convince the other hospitals to give those patients up and let them come to us is not a problem. They were always seen with a lot of stigma and rejection, and nobody wanted to really look after the overdose patients. So organising this as a centralised service, which is what this sort of, well, the details, but what this diagram here sort of demonstrates is what we set up in 1991. And we run it not only as an integrated clinical service on an area-wide basis, but we have an associated case register for every patient. So for every admission of people who come to our unit, there's a toxicological part of the database and a mental health psychiatry part of the database. And at the moment, after many years of doing this, we have 25,000 odd admissions in that case register, which we use for training. And this particular set of data you don't need to worry about. But when we first set up, people said, you're going to bring everybody to the same place. You're going to make sure everybody gets a mental health assessment as well as the especially toxicology assessments. That's going to cost too much. It'll be too hard to do. And these tables just demonstrate that we're able to provide mental health assessment to about 98, 99% of people, and that our diagnosis-related weighted costs were much less than the New South Wales state average, much less than the national Australian average. So we were able to make this scheme very early on, and it's cheaper to run it this way than in the traditional way. Now, the magnitude of the problem, so taking an overdose or cutting yourself from coming to hospital varies by nation, but it's still common wherever you go. So in Australia, the best estimate's around 200 per 100,000 per year. In the UK, it's probably close to double that. In the UK, it's thought to account for, in London, around 10 to 11% of all ED admissions. So this is a big part of presentations. So this is a big part of business at the emergency department. And until recent decades, mental health services didn't always have much of a presence in the ED for managing these patients. And it's starting to change, at least it's starting to change in most countries. So there's a wide range, but it's still common and it's expensive, and any repeat is an expensive thing that we'd like to try and avoid. From the systematic reviews and meta-analyses, the most common form is the poisoning form, so a median of around 90%. The absolute risk of repeat is low, so around about 15% to 16% will repeat in the following 12 months. So 85% of the people you see in ED won't come back in the next 12 months, and most of them will never come back again. It's a once-in-a-life experience. But 15% of people will repeat, and some of those will repeat multiple times. The suicide risk is also, the absolute risk is quite low. So the absolute risk after a year's follow-up is about 1.6%. After about 10 years follow-up, 5 to 10 years follow-up, it goes up to about 4%. So 1 in 25 people who turn up with an overdose at your hospital will die by suicide over the next 5-year period. So it makes them the highest risk clinical group for suicide, and the relative risks compared to general population, et cetera, are enormously high. People quote figures of 300 times, 500 times, although the absolute risk is still quite small, only 1.6%. The repetition burden is not evenly distributed, and I'll show some data for that later. So a lot of people just turn up for one time. So in the early days, this is part of the sort of idea generating part of the the translational continuum. We were looking at the figures that you could find in those days for how common and how expensive this was. And this is a very early paper from the mid-90s by David Owens and Alan House, and you probably can't read it here, but it sort of says the things I was saying. In those days, deliberate self-harm in London accounted for about 11% of all ED admissions. About 1% of people died by suicide after 12 months, so that hasn't changed very much. And the services were disorganized, expensive to give, but not very effective. And there was these were the early days of telling people that they had to organise their services, and it was concurrent with the time when we were doing just that in Australia. The same group went on to do a lovely systematic review and meta-analysis of those two outcomes: repetition, the binary repetition of any further episode in 12 months, and generates the figures that you can see here for repetition and for suicide deaths. So suicide deaths is down in this one. Sorry, I might be reading them backwards. Okay. And then a later and larger, obviously, systematic review and now meta-analysis by O'Carroll and his group out of Bristol came up with pretty much the same answer. So 1.6% of people die by suicide in 12 months, 16% repeat at least once. And those figures are a bit lower for Southeast Asia. So repetition rates probably down around more like 10%, not massively different. And this is what I'm going to tell you about. It's not evenly distributed. So this is a study we did early, but there's lots of studies that say the same thing. So in Newcastle in Australia, here's our repetition rates, around about 13% after 12 months for all patients. But there's a major diversion. So if you had a previous self-harm, your repetition rate's probably more like about 30%. If you hadn't done it before, then your repetition rate's probably 10, 11%. So the people who repeat multiple times is the message here. And the people who don't repeat, the vast majority of folks who turn up to the emergency department with an overdose, you'll only ever see them once. They won't come back again. And that's important when it comes to the metrics of trying to figure out what you should measure for effectiveness. Okay. So that was the sort of idea sort of phase of the translational thing. And now it's the sort of feasibility, generating an idea about what we could use, what might be a useful intervention that you could deploy to everybody that is feasible and affordable. And so there was a whole range of brief contact interventions that started in the 70s and 80s. They were basically green cards, telephone sort of contacts, and our sort of postcard sort of letter writing contacts. So I'll tell you about the green cards first. These were all sort of UK studies. They're pretty well done given the standards of the time in the 70s and early 80s. And the green cards sort of were, again, deployed in hospital-treated self-harm patients, mostly self-poisoning patients. Originally, they were a token to allow you to get into a hospital admission without any questions asked. That is to say, if you ran into another psychological crisis, relationship crisis, fall off the wagon for alcohol dependence crisis, worsening of your depressive illness, relapse of your bipolar illness, whatever it was, no questions asked. You had this green card that was actually a ticket to get readmitted if you needed. People very rarely used it. It's probably far more reassuring to carry in your pocket than it is to actually have to use it for admission. And after a time, that became a bit prohibitive as everybody worries about hospital beds and people unnecessarily taking up beds. And it translated into a green card, which authorized a direct telephone contact with the psychiatrist for your area, for your ward, for your service, so long as you hadn't already taken an overdose or cut yourself. If you had already taken an overdose, cut yourself, you had to go to the ED in the usual way. So the idea was to prevent emergency department presentations, some over-the-phone counselling, 24 hours a day availability, which was probably one of the reasons it died out. I think the psychiatrist got a bit sick of doing that. And they tested it in various randomized controlled trials. They were generally underpowered, but they were multi-center. There was this same problem with measuring repeat self-harm and how to measure it and what the correct metrics are. I'll talk more about that later. They mostly used the binary outcomes of whether you had a single, any further episode, although I've told you that if you have a single episode, you're more likely to have multiple episodes. And it probably makes more sense if you're a third-party provider, if you're the hospital administration, to cut down on the number of episodes. And, you know, this is not unusual in medicine, so you have to pick the endpoint that makes some sort of sense. So let's sort of talk about cardiovascular disease. If your endpoint is a second heart attack, then that's a very preventable, sensible, binary sort of outcome, and that's probably what you should measure. But if you're a neurologist who deals with migraine, trying to have an intervention that stops any possible, you know, reoccurrence of migraine in the next 12 months is probably completely unrealistic. And the more sensible, appropriate sort of metric that we use for migraine is either a frequency of attacks or severity of attacks or some combination endpoint of frequency and severity. And the idea is to try and cut those down. So deliberate self-harm repetition is probably more like migraine than it is like a binary endpoint like a second cardiac event. It was never quite clear, but some studies showed benefit and some didn't, and it wasn't, there was some signal there of benefit, but it probably wasn't too overwhelming, and they've dropped out of popularity. Nobody uses them now. Well, nobody much, I think, uses them now. And again, the people who actually use the contact that was embedded in the contract to have the green card was actually very small. So it didn't provide much extra additional cost to the services. The next variations were telephone calls. So again, several places that have followed telephone calls, particularly the French sort of studies. Very feasible, very acceptable. In the non-randomized control design, so mostly sort of cohort designs, they had very promising effect sizes for a binary repetition of any repeats. But once the randomized control trials were done, multi-center, adequately powered, variety of measures of how they looked at repetition of self-harm, there was very little signal for any benefit. And here's a meta-analysis that we did just recently. So here are the non-randomized controlled trials, and you can see if one is the game line on these forest plots, that, you know, there's not terribly much heterogeneity and it tends to show a benefit. But once you move to randomized controlled trials, eliminate a lot of the biases obviously inherent in cohort sort of designs, everything clusters around the unity, and there's really no sign of benefit for telephone. So there's something about telephone calls that doesn't work. Now, letters and postcards. So this is where we got our original idea from. There was an earlier study that wasn't available, it wasn't published, it was actually only in a conference proceeding that one of my mentors had been to, and that was how we came across it. But this is from the later publication. So there's a guy called Jerry Motto and his colleague Alan Boston, and they were in California, in San Francisco. And he had a slightly different population. So Jerry had a population of very severely depressed people admitted to the psychiatric ward, so inpatients with severe depression. And he had a group of those folks who, no matter what he offered them for follow-up care, they were emphatic that they were not going to attend. They didn't want to come to the clinic. They didn't want to come back to the hospital. They didn't want to have home visiting. They didn't want to participate with follow-up. And he worried about them from the point of view of suicide. And so he designed this letter writing intervention to try and address that problem. Now, the graph is slightly complicated. I'll show this one for the first 5 years of this study. So this top line are the people who weren't in the study. So these were the people getting usual treatment at the hospital who were very happy to turn up for follow-up care. And you can see the first thing that's odd is that their suicide rates are greater than the people who weren't going to turn up for care. So he was picking, in terms of the endpoint, a more difficult population to demonstrate any benefit. So that top arm is the folks who were going to take the usual treatment and do follow-up, and their rates of suicide, or their numbers of suicide as it is here, after 5 years are actually higher. Here are the intervention and control groups, and this is the control group, this is the intervention group, and you can see that for the first 2 to 4 years, there's quite a separation, although the numbers are very small. And looking at this more critically in these days, it certainly could be regression to the mean. It's hard to, you can't prove it one way or the other. But this is the original signal that we saw in this letter writing intervention that we thought we might be able to feasibly translate to our general hospital population. Here's the 15-year follow-up, and you can see that after they converge, that there is the first part of that graph. And then you can see they just converged. They never had the same suicide rate as the people who are happy to have follow-up. In retrospect, it would have been nice to recruit them to such a trial, but nobody's ever done that yet. And this was the intervention. He wrote to them in a letter writing intervention for 2 years. And it was very simple. It said, "Dear person's name, it's been some time since you were here at the hospital and we hope things are going well for you. If you wish to drop us a note, we would be glad to hear from you. Sincerely, signed by Alan and Jerry." So very simple note. All it just says is, we're still thinking about you. We do care. If you need help, we're here. That's it. They sent it once a month for 2 years. And so that was basically what we decided to run with. But parallel to this, over in the United States, they really love this study and they've embraced it in the veterans community. So now this is a big deal for them. They don't evaluate it, they've just implemented it. So US veterans, either all in a given area, battalion, whatever, or some high-risk groups, people who are in the psychiatric hospitals, get these sort of care and contact interventions, as they call them. They use all modalities: letters, telephone calls, emails, SMS, and some online sort of stuff. They're certainly feasible, acceptable, and scalable, and certainly inexpensive. So in a 12-month period, they sent to 100,000 veterans, US veterans, over 500,000 letters, as well as phone calls and other contacts. Out of the 100,000 approached, only 36 refused to be involved. So it's pretty acceptable to people. They don't see this as terribly intrusive or traumatizing or unpleasant. And the way they do it in this US system, if I can get here, is they have a card from peers. So they have veteran peers who write to the veterans, as well as the health providers. They give it. Now, they don't evaluate any of this. So I can't tell you whether it's effective or not. I can't tell you what an effect size would be, but they certainly have implemented it big time. These are the sort of cards they send. I don't know if you can read that from here, but that's a peer card and that's a health provider card. They have a lot of the same component messages from the original Jerry Motto study. And in Newcastle, that was what we translated into a thing called Postcards from the Edge. And this was a letter writing intervention that we sent to people for the first 12 months after they've been at the hospital with an overdose. And here you can see the two lines diverging. So obviously this is the intervention with benefit. This is the control group. And this endpoint is the number of events per person. So this is not the binary endpoint of any further attack. This is like migraine, the number of events per person over the next 12 months. And, roughly sort of 50% reduction. So if you look at the incident risk ratios over here. So after 12 months, which was the duration of the intervention, about a 50% reduction in repetitions. So this is 24 months. So that part of the graph you've already seen. This is the extra bit, continues on, doesn't converge. After 5 years, you've seen up to here now, and 5 years, same incident risk ratio, so about a 50% reduction in repetitions. And so the behavior changed in some way, even after we stopped writing letters. People who didn't repeat as much as they used to continued to not repeat as much as they used to. So that's a very enduring effect from a very small, inexpensive intervention, 12 postcards over a year. Now, our postcard was very similar to the Jerry Motto original, and it had best wishes from Andrew Dawson and Ian White. Andrew Dawson, some of you in the audience may know, he spent a lot of time here. I think he lived in Candy for about 8 years, helping set up and run the toxicology unit. And he was one of our toxicologists on this original study, and his boss was Ian White. And so it came to the patient, signed by the toxicologist who would have had their name on the end of the bed. So they sort of knew who this was coming from. But essentially the same message as the original Motto study. Pretty cheap. Okay. One of my colleagues who trained in toxicology in Newcastle and came from Iran, went back to Iran, and he ran the same sort of study there. He looked at our postcards and said that culturally that wouldn't really fit in Iran and it needed to be a little different. So they modified the content and the appearance of the cards a little bit. So a slightly different intervention. I didn't put up the effect sizes, but it was also beneficial. You'll see some of it here. So we did a systematic review and meta-analysis to look at these brief contact interventions of various sorts. This was split into first 12 months or 6 months, first 12 months or less for this group, 12 months or more for the second group, and a summary diamond for meta-analysis here on the forest plot. So this is the binary outcome of any repetition. And as I said before, probably not the most appropriate one, not quite statistically significant. So a little benefit, most of them on the right side, the correct side of the line. So some reduction, but not statistically significant for the binary outcome. But there were 3 studies that we could pull for meta-analysis of the event rates, the number of episodes per person for an incident rate ratio, and quite a substantial benefit. So there's ours that I just showed you. That's Hussein's one from Iran, and this is from Christchurch in New Zealand. So all on the same side of the line, all, similar sort of effect sizes. Overall reduction, incident rate ratio about 66%. So overall reduction of about 33% of events, further events, the number of self-harms. We had a look at suicide as an outcome at the time. None of these studies were powered for this. Suicides are relatively infrequent outcomes statistically, not statistically significant, but again, all pretty much if they were any effect of benefit, so a non-significant sort of possible signal for suicide as an outcome. That is a binary outcome, of course. Okay, now on the research continuum, if you've established that you can do this in one place and perhaps a second place connected, now you've got to try and run it in a hospital system and see if it still works under real world conditions, I guess is the expression that people often use for this. And so that's exactly what we did. So this has been reported in British Journal of Psychiatry last year, I think. So we went to Sydney in Australia, and we went to 3 of the big teaching hospitals in the west and southwest, west of Sydney. So Westmead Hospital at Parramatta, Nepean Hospital at Penrith, and Blacktown Hospital at Blacktown. And so we modified the postcards to now be an SMS intervention, so people get a text on their phone. This was a standard sort of individual randomized controlled trial. And you'll see the same sort of separation that we were seeing in the other graphs. And this is after 2 years. So again, our intervention went for 1 year, and you had about a 22% reduction. And that was maintained in the following year, even though no further intervention was sent. So I can't remember exactly. That accounted for a saving of, I think, 350 odd presentations at the big general hospitals in Sydney. And, if you can save 350 presentations in a year across 3 big hospitals at the emergency department, that's probably a good opportunity cost saving for an ED bed to do somebody else's care. This is not our work, but this is friends and colleagues at the NIMH in Washington, DC. This is not a direct cost effectiveness study where you go and measure qualities in every patient. This is a modeling exercise by Schoenberg is the main sort of modeler in all of this. But same sort of principles as cost effective, except there's a whole lot of assumptions obviously built into the model, so you have to be a bit cautious. Down here is the cost per saving. So for saving for a quality, the saving of one quality adjusted life year, the usual standard is that people would be prepared to pay, hospitals, governments, individuals be prepared to pay $50,000 for one saving, for saving one quality. So it's probably hard to see, but for the postcards, I've never seen this in any other quality assurance project, there'd actually be a net saving for each quality because the intervention is so cheap, because the number of hospitalizations and the quality of care, that quality of life that would be involved with all that is so great that the postcards actually save money for quality yield. Never seen that in anything else. Telephones on their data, it was reasonably cheap for quality, and CBT also effective, but obviously a bit more expensive with face-to-face psychology trained intervention and actual therapy, of course. Okay, so now we've got to look at the problem of we've developed it in one hospital, we've tested it in, let's say, Iran and New Zealand, 2 other hospitals. We've rolled it out in a real hospital system across 3 hospitals in Sydney. The next step is, can we roll it out across the state and then maybe ultimately to the whole country? So a brief word here about study design. So in order to, you could just roll it out, which is what they've done in the United States, and not evaluate it. But it seems to us that there's a real opportunity to evaluate it. And we're aware that a randomized control design is the best way to have an unbiased estimate of the effect sizes at the end of the day. But trying to, so this first diagram represents a standard individual randomized control trial. This one's a cluster randomized control trial where the clusters in this case would probably be hospital EDs. And you can randomize based on clusters, or you can use the thing called a step wedge design. I'll show you a better diagram in a minute, which allocates where the randomization is about the time spent in control period and the time spent in intervention, and you do it as a cluster, usually do it as a cluster. So this is ideal sort of randomized control design when you're trying to roll out a service across a big area. Everybody wants the service first, so you've got to convince them that they've got to go into the randomization pile and take their turn when they're given out. But apart from that, it's a quite efficient way, because usually you can't just do this across the whole state in one go anyway. You want to do it in one health district and then the next health district, etc. So this is a way that allows you to do it that way, but to evaluate it as a randomized control design. It's called a step wedge design. So if you remember, so this is how we plan to do it for New South Wales. We haven't done this yet. We're up to this stage. This is the next grant, next bit of work. So we have 12 clusters with, I think, 280 hospitals in New South Wales. I'm not quite sure of that number now, but they're all, split up evenly and put into the 12 clusters. So everybody starts on the control condition, which is doing exactly what we do at the moment. No change. And then one by one, there's a step where the first cluster starts doing the intervention. And then there's a second step. I can't get this to, I think my battery is dying. Second step, anyway, you can see the step. So the way we propose to do it is every 2 months, another cluster of hospitals will start rolling out the postcards. It's called a stepped wedge design because there's a step for each time you add on a new cluster. And the wedge is the part where you analyze. So you analyze the time on control, the control period against the intervention period. And as you can see, when you look at it, they're equal. They're a wedge. But the randomization is based on the time you spend in control. So it's a somewhat different design. Most people aren't used to it, but it is a randomized control trial, can be analyzed and interpreted in the same way. You do have to adjust for possible secular changes over time. And you do have to make an adjustment in the analysis in a GLM model analysis for a difference in base rate. So let's say that the base rate of repetition was much bigger in cluster 2 than cluster A. You can put in an intra-class correlation coefficient into the statistics. I won't bore you with the statistics, but a way to adjust for that. So it's a good way to have a randomized control trial that still mirrors the sort of Department of Health rollout of an intervention that you might normally do. Its greatest success for this design has been in Africa with the rollout of vaccines and that sort of thing. We're doing a slightly different version. I won't go into this terribly much, but if you can see the parallel of the dark blue, which I just showed you, there's another parallel of light blue to the right, and that's a sort of extended cohort follow-up. So just a bit fancier. So to try and summarize what I've told you today, brief contact interventions can be delivered to everybody who turns up at the ED, pretty much. If you don't have a phone, we can't send you an SMS. If you don't have a home address, I can't send you a letter. But pretty much universal. You don't need risk stratification. You don't need to select out particular subgroups. You can apply it to everybody, pretty much everybody. Feasible, doesn't cost much. We've deployed it in various hospital systems. We've shown its effectiveness. The size of the effect size varies a little bit from place to place, but even at the least of 22% reduction in repeat episodes, that's a big cost saving for hospitals if you only look at it from that point of view. The modeling suggests it's very cost effective, which you would expect given the very low cost. It's a very clinically meaningful benefit for service providers because it's not just a dollar saving, it's an opportunity cost saving. All those beds are available to treat a heart attack or to treat a trauma victim or whatever. It might be important to have a good ED experience for these patients. If you come to my ED, we've trained our ED physicians and nurses over a long period of time to be compassionate, to understand that overdose and mental illness is not to be stigmatized, that people are looking for help. They're not just attention seeking. They're not trying to annoy you. They're not trying to use up a bed that would be better for somebody else. You shouldn't tell them that if they're really serious about suicide, they should jump off the cliff instead of taking an overdose. So we've worked on that for a long period of time. And so when we write to them and say, we still care about you and we really hope things are going okay, that probably gels pretty well. But if you're an old-fashioned ED where they do abuse you, neglect you, suggest that you should kill yourself with a better method, and then I write to you and say, we really care about what happens to you, maybe that won't work so well. So you probably have to do some work on your ED. It's possible there's a downside to some of this, like we're writing a letter that might remind people of a probably very difficult time in their life when they're at the hospital after an overdose. But the feedback, the sort of qualitative feedback we've had from people hasn't suggested that that's really a problem. And so we don't think re-traumatizing is a big deal. So